Hello, my name is María-Victoria Mateos. I work as hematologist and a director of the myeloma unit at the University Hospital of Salamanca in Spain. And I will present the challenges and the future directions in monoclonal gammopathy as well as smoldering myeloma, two precursors diseases that always precede to multiple myeloma. The first challenge is the diagnosis, and in 2014, the diagnosis criteria for multiple myeloma were updated, and in order to do the diagnosis of MGUS or smoldering myeloma, it is extremely important to ruling out the presence of a myeloma-defining event. And also, it is important to wait at least 3 or 6 months in order to confirm the stabilization of the M component as well as the absence of CRAB symptomatology for doing the diagnosis of MGUS and smoldering. In the future, maybe we will expand the definition of multiple myeloma by the incorporation of new biomarkers that will predict in asymptomatic myeloma patients imminent risk of progression to multiple myeloma. The second challenge is screening programs, yes or not, and based on the I Stop Multiple Myeloma project, we have not to do yet screening programs for the early detection of either MGUS or smoldering, but maybe based on the high prevalence reported in this observational study, especially for smoldering, 0.5% of the population older than 40, and especially because the screening changes the way in which the disease is presented, and we are going to avoid acute presentations, and we are going to avoid CRAB symptomatology in our myeloma patients. I think that in the future, maybe we can have screening programs. The third challenge is how to stratify especially smoldering myeloma patients according to the risk of progression to multiple myeloma. And it is well accepted that the use of clinical markers like the M component, the plasma cell bone marrow infiltration, and the free light chain ratio, including the 2-20-20 model, is a valid and worldwide model to stratify patients with smoldering myeloma. New approaches are coming based on genomic information that will complement these clinical markers that we have to use every day in our patients with smoldering, because it is mandatory to evaluate the risk of progression to myeloma. The other important challenge is to plan early treatment, yes or not. Point number one, there is not any drug approved yet for smoldering myeloma. But there are some evidence, at least 2 academic phase 3 clinical studies reporting benefit for the early treatment with Len or Lendex in this population, high-risk smoldering myeloma. Many clinical trials are coming, and we will have in the future drugs approved for high-risk smoldering myeloma. Monoclonal antibodies anti-CD38 like DARA single agent, or maybe DARA or isatuximab in combination with Lendex. But of course, the new immunotherapy strategies like bispecific monoclonal antibodies and CAR-T are also coming to the treatment of smoldering myeloma patients in which the immune system will be better than in myeloma, and maybe the efficacy will be also superior. Also, another challenge in which we have to work is in the primary objective. We want just to delay the progression to myeloma, or maybe we want to eradicate completely the disease to cure the disease. And I would like to summarize saying that many basic translational and clinical research is ongoing in MGUS, and especially in high-risk smoldering myeloma. So I am completely confident with all these efforts we are doing in order to plan early treatment for high-risk smoldering myeloma, at least for delaying the progression to multiple myeloma, but maybe we will be able to cure the disease in some of these patients.